being the first starter, panghimagas. And let me just start my screen. So can you see my slides, Anne?
We all see your slides.
Okay. So again, good afternoon. And I think with the number of attendees here, we can see how we nephrologists are very much interested in the management of anemia and what's in store for us for this afternoon. So actually, the holy grail of anemia therapy would be increase in hemoglobin level, of course, improve the quality of life, reduce transfusion requirement, and avoid adverse events. So these are my outline that I'd like to follow tonight. Look at some data regarding prevalence and zero in on the pathophysiology of anemia in CKD. What do we do and what do we use? And the newest agents that are now coming, and that these are the hip stabilizers. And of course, there is really more in terms of future therapies. So first, let me start with the prevalence. And this is just one of the examples that I'd like to share with you from the National Health and Nutrition Survey in the United States, which shows to us that as far as the general population, it's about 6.3. But you can see here the definition actually of anemia before is a hemoglobin of less than 12, and now it has been accepted that it is apparent that we start treatment in CKD if your hemoglobin is less than 10. And as you worsen your CKD stage from 1 to 5, you can see that the prevalence of a hemoglobin less than 12 reaches about 53.4%. And as far as the reasons why anemia develops in CKD, there was a time that it was just very straightforward in that there is really a lack of erythropoietin, which we know is really the hallmark because of diminishing renal mass. But we now know that this is not the only case. In fact, it seems that the difficulty in using erythropoietin is borne out by the fact that there are a lot of mechanisms coming forth, which zeroes in on the accumulation of toxins as CKD progresses. Also, you can see that inflammatory mediators, such as particularly hepcidin, the main iron regulator, increases as well as CKD progresses. And of course, we know about the suppression of erythropoietin production and the shortened lifespan of the RBC. And of course, as I said, iron deficiency is another problematic arena. And this is not only because of lack of intake, but because of the progressive loss of blood as you are developing venipuncture to monitor your CKD. So this is just to show to us that really as you increase CKD severity, and this is a logarithmic interpretation, you can see that there is really a impaired serum erythropoietin response. So it's flattened here, and you can see that the hemoglobin is decreasing as you worsen CKD from 1 to 5. And the other thing is that there is shortened erythrocyte lifespan. And one study shows that it is shortened from 120 to 70. And therefore, in this relationship, you can see how as you shorten the lifespan of RBCs, for example, here, you will have to require higher doses of EPO to be able to maintain your hemoglobin in dialysis patients. But as I said, the real reason is that there is really diminished EPO production. And it is very well known that erythropoietin is produced in the myofibroblast cells in and around the tubular epithelial cells. And as you can see, this sensing of oxygen supply and the relationship of the sensing as far as tubular function is concerned is a hallmark of which the HIP regulators has been described. No? So it seems that diminishing the myofibroblast, so there is loss of transformation of these EPO-producing cells. Also, the balance between oxygen supply and consumption is not as great as before, and the inhibitory signals as well. And then other possible causes and possible reasons as well. So as far as the renal failure progressing also, it has been known before that these transformed cells, the myofibroblasts, which has transdifferentiated and has failed to produce EPO, it was known before that this is no longer a reversible phenomenon. But now it seems that this transformation can be reversed, and that is the reason why we can use the phenomenon of hypoxia inhibiting factor stabilization to be able to recoup the lost erythropoietin produced as CKD progresses. So these are what has been learned. And of course, the importance of what is needed as your precursors mature from the erythroid precursors, your burst forming unit, up to your mature RBC. We know that from here to this maturation, it is erythropoietin dependent. But from this to the erythroid or the RBC, iron is really the important factor that is needed for full maturation. And this just shows us, these are rat examples, wherein they were not given iron, and as iron was repleted at day 4, you can see how the marrow, the spleen, was able to have the maturity that is necessary because of the repletion of iron. So you really need ESA and iron, and that's good. And actually, it seems that as we were progressing in the knowledge, giving erythropoietin was the way to go, but iron was another way, as explained in the earlier slide. But we now know that there are intervening factors that prevent anemia from being ideal. And the number 2 factor now are the toxins or the uremic inhibitors to erythropoietin use. Also, it has been put forward about iron availability, which is really prevented as far as this master regulator of iron, which is hepcidin, which we now know is produced when there is inflammation. So hepcidin coming from the liver has several actions in terms of preventing the iron release, iron absorption from the duodenum, and also the reuse of iron that has been stored in the spleen and in the liver. So it seems that the understanding of erythropoietin before was that you give erythropoietin to patients with CKD, you will definitely improve anemia because this is a information that has been with us. But you can see from here that really the amount of erythropoietin given, if it's too much, will be the one that will lead to the effects that are unwanted. And as I told you, there are other important factors now that has been identified, like the inflammatory stimuli, like interferon alpha, TNF alpha, interferon gamma, and IL-6, which you can see here will interfere with the maturation, will enhance erythrophagocytosis, and diminish the lifespan of the erythrocytes. Also, the important increase in hepcidin, which will prevent the release of iron from the storage, such as macrophages. And finally, the transferrin, or the transfer iron that is needed for iron to be utilized, will be likewise acted upon by these inflammatory stimuli. And finally, these cytokines, which diminish or restricts iron and suppressing erythropoiesis, will allow maturation towards the myeloid series and not to the erythroid precursors. And that is also the reason why infection can be a problem with iron that is excessive. So as we go through how we manage anemia, we were in 1987 using a lot of blood transfusion, using a lot of adjuvants, and of course oral iron, but this was not really satisfactory. Upon the introduction of ESA, that has really revolutionized anemia management in CKD, but the problems were we were overusing it. And then we have questions whether we needed to start first with iron or ESA, or at the same time. And then, of course, we now have the HIP alpha stabilizers. And the newer ones will be the ones targeting your EPO receptor directly. And also, there are now even newer ones wherein there is EPO gene therapy. And who else? Who else can predict what can follow? There's even a journal on artificial intelligence on how to mix and match all of this to be able to arrive at the ideal management. So we have been guided by the trials. So as you can see, from 1987, upon the introduction of ESA, the first trial came out almost a decade after. And these are trials that are trying to know what is the ideal hemoglobin target. So this has been shown to us also in the next studies here that are also landmark trials. And then came the studies of IV or oral iron and high dose or lower dose. So these are as far as the DRIVE study. And recently the pivotal trial also, which used a higher dose of IV iron to be able to address the question of whether it's IV or oral iron. And now we have the HIP stabilizers, and we have 4 already in the pipeline, for which, of course, roxadustat was the one who was the first one to come out with their phase 3 trials. So there is really a lot of guidance as far as anemia. And I'd like to highlight the very first that we are really using. Of course, we have others like the KDOKI, but we have the KDIGO in 2012, and to be able to say immediately that adjuvant therapies are not recommended, and this is a 1B recommendation. And also the other adjuvants such as vitamin C, D, E, folic acid, even L-carnitine and pentoxifylline are also not advocated, and that's a 2D recommendation. So just to settle in first with erythropoietin. So I said that it was first discovered 33 years ago. You can see here. And a lot of people were really playing with the dose and were targeting from 15 units per kilo to around 500 units per kilo, and really exceeded or targeted a very high hematocrit. So we know for a fact that the improved quality of life is the most important outcome that was seen with ESA. However, 30 years after, there are concerns that are appearing already, and we see hypertension worsening, we see hypercoagulable state. That's why there's vascular access problem. And therefore, this limited the nephrologist from using or targeting a very high hematocrit with very high doses. But of course, survival is really better with higher hemoglobin. So these are hemodialyzed patients, which were followed up. And you can see the survival with hemoglobin of 13. And these are non-dialysis CKD patients, again, targeting 13. And that is what we were having before the RCTs came along. And as I said, this has really tempered the amount of ESA that we are using. For example, the choir targeted now lower, 11 versus 13. The CREATE targeted 10.5 versus 13 to 15. And the TREAT trial even targeted the lower hemoglobin of 9. So as you can see, in this non-dialysis and the dialysis population, it was shown that targeting higher hemoglobin levels resulted in bad outcomes such as CVs, worsening of kidney function, and even death. So therefore, that has brought about why we are not targeting those high hemoglobin levels anymore. That is why there is a sweet spot of 11 and not go above 12.5, which is very difficult actually, because we know how we would like to change the dose and then overshoot and then have a problem again of decreasing the dose. And I'd just like to show you that even the Canadian, for example, the people from the United Kingdom, also the Americans and the Europeans were saying the same target as far as hemoglobin. But actually it was the European who said that customization is probably the way to go. So you can see here in green, they're allowed target hemoglobin, allowed TSAT, and allowed ferritin because of the diversity of the population that we are treating. So they're saying that the Europeans would like to personalize their target hemoglobins. And of course, we now know the reason for this. For example, in heart failure, in patients with cancer, you cannot just follow one hemoglobin level for this population. Also, we know that if you are having an endpoint which is reduced transfusion as compared to exercise capacity, you know that this will be your guidance, but however, you must be tempered by these particular factors down, which can also hamper when you have high hemoglobin targets. And this is just one example of how we nephrologists are able to manage and try to do our own thing. You can see here 632 non-dialysis dependent CKD with GFR of 23. And they were following this patient for 3.5 years. So you can see ESA use versus short ESA versus long ESA. But what is very important to imagine or to accept here is that the risk of having an event, and here it is ESRD or worsening kidney function, was more dependent on the ESA dose, and it was more in those with short versus long-acting ESA. So that is why you really have to know and personalize whatever outcome you would like to have. So that particular guidance in the USRDS has been very changing in terms of their practice patterns. So you can see here how the United States now have targeted a hemoglobin of about 10.5 and how erythropoietin use has declined, not only the use but the dose, and also concomitantly a very small increase in the use of blood transfusion. So also, I think this has been brought about by the bundles in the United States in terms of reimbursement. But nevertheless, it has also its good thing. So this question is because of the availability of the innovator, ESA, the alpha, beta, and now zeta. We have the pegylated and the long-acting. There is a question of which ESA therapy to use. And of course, the problem of the biosimilars, which has really been a lot of presentations in the past decade. No? So this is just to show you 56 studies. It's a network meta-analysis of around 15,000 patients. And of course, you know, the problems with network meta-analysis, wherein the risk of bias is generally high, no, in these studies. But just to highlight that whatever ESA you use, and here what was used was alpha, darbepoetin, the biosimilars, pegylated. So you can see here whether it's an outcome of mortality, transfusion, cardiovascular disease. It seems that all the dots here are towards the midline, and all the confidence interval are crossing the line of unity. So there is really no difference. No? The only thing that they're saying is that the innovators, alpha, beta, and darbepoetin, are the ones that have shown, of course, in the important trials that I mentioned a while ago, as comparators in RCTs, and that is why they are the ones also that have been used generally in a lot of settings. So, of course, you have to remember that there are certain contraindications to ESA use. So I just mentioned a little bit here. There was a problem with PRCA, and I think it was a good thing that they were able to identify, the culprit for this. But just to really tell you that hypercoagulable disease states is also problematic. And the decision of whether to give it in cancer patients should also be a decision that the doctor and the other doctors managing the patient will have to arrive with at the same time. So just to highlight some ideas regarding EPO, hyporesponsiveness, and just to show you that there is a journal published in 2016 in the AJKD wherein they studied prevalent hemodialysis patient in a span of 1 year. And the definition of ESA hyperresponsiveness in this journal was 2 consecutive hemoglobin measurements that is arriving at 10 grams per deciliter with contemporaneous ESA dose. And that is a very large dose of 7,700 per treatment, which will actually be around 23,000 per week. So for those of you who are still doing this, you might would like to consider ESA hyperresponsiveness as an etiology. And in fact, there was even a suggestion to define EPO resistance index. No? And this is defined as your dose of erythropoietin per kilogram per week divided by your hemoglobin level in grams. So it is assumed that this method is more efficient in detecting EPO resistance. So you may do this in some of your patients, but know that there are a lot of reasons why there can be EPO hyperresponsiveness or ESA resistance. Now, this can be patient factors, and mostly they are comorbidities. Mostly this will center on now if we have our patients living a lot of years on dialysis, secondary hyperparathyroidism. Also, the nutritional status can be another problematic area. There can be intercurrent events happening or medicines. For example, your ACE inhibitor ARB decreases erythropoiesis, and sometimes that is being taken as a culprit, no? Or certain practice patterns, and if you have identified all of this not to be present, then you might as well look at these practice patterns as far as hyperresponsiveness is concerned. And just like to show you some data on dialysis modality. So this is a retrospective multicenter study comparing 4,772 patients on regular HD and hemodiafiltration, 24 months of follow-up. And you can see here that the ERI, the erythropoietin resistance index, dropped in the HDF group, and also the ESA requirement was lower as well in the hemodiafiltration group. So you might like to consider this in some patients when you are already at a quandary or at a loss. No? So change your dialysis prescription and your dialyzer. So the next, of course, after ESA is iron. No? So you can see here that iron deficiency anemia can be functional or absolute. And the problematic one is really the functional iron deficiency anemia. And as far as the role of iron now, actually, I said a while ago that the hepatic iron regulatory hormone hepcidin seems to be the master regulator. And once you understand this important relationship, it seems that you will be more confident in using iron and making it your friend rather than your foe. So we know that hepcidin increases because there is failure of clearance of the dying kidney, and also there is production of hepcidin from the liver because of inflammation, which of course is also increased in patients as they go through worsening CKD. So all this hepcidin will act in all of these important areas wherein iron has to be either delivered, has to be released from its storage, for example, from the macrophages, or from the spleen and liver when it is needed to be recycled so that it can be now reused again. So if you diminish hepcidin, therefore, then you will be able to address this problem of inflammation secondary to iron. And now they're saying that the important carrier, no, which determines your TSAT in states such as high hepcidin states, no, this tells us that there is failure of reabsorption of dietary iron if you have hepcidin, as well as if they are absorbed, there is also failure of release from the macrophages and uptake of the erythrocytes if you have high hepcidin compared to low hepcidin. So that is why, again, that's the importance of really trying to address inflammation. And proof of concept of this is showing to you in pediatric and adult population. And as you worsen your CKD, both in pediatric and adult, you can see the increasing hepcidin levels. And this is also true as far as your patients going through worsening CKD. And this is the other problematic thing. Hepcidin is cleared by dialysis. You can see this study showed diminished hepcidin, but after dialysis, immediately on the first hour and in the third hour, the hepcidin levels are already back to their usual or their initial state, no? And will remain to be such until the next dialysis. So it's really one of the reasons why we still have problems with anemia management, because we have not yet really attacked this particular mechanism. So the new options, therefore, for iron supplementation has been to be really knowledgeable and to monitor well what you needed to know to be able to drive your erythropoietin to work. So you can see here through time, there are a lot of iron that has been manufactured. No, there is even an IV iron, there's carboxymaltose, there's even iron that can be now paired off with a phosphate absorber. There is also an iron that can be used, ferric citrate, so you can even give this during dialysis. No? So there are also a lot of progress in terms of iron. So as I said, the clue actually in managing iron problems are knowing if you're dealing with absolute or functional. No? So you have to monitor your TSAT and ferritin. And of course, you see here that in functional iron deficiency anemia, you will have a high ferritin and a low TSAT. No? And there are other ways that have been put forth. For example, your reticulocyte hemoglobin content. This measures the absolute amount of hemoglobin in your circulating reticulocytes, and also your percentage of hypochromic cells, now, which will now measure the concentration of hemoglobin in RBC based on an absolute hemoglobin content. And the following will be the thresholds, more than 6% for your HRC and CHR of less than 29. However, I know that these are not yet available here for us to use. Of course, you can see here hepcidin can be another thing to monitor, as well as your transferrin receptor ferritin. So actually, I told you at the onset that there was a time, and this is a very old study of 52 patients, no? Wherein oral iron was the first one that was being given, and it was compared to IV iron. And you can see what happened to the hematocrit when you're using IV iron, and also what happened to the decrease in ESA dose with IV iron. And in fact, when they're studying iron in terms of outcomes, this is one of the outcomes that they were always looking at. No? If the iron is able to reduce the ESA dose, then that is a good study. And these are all the authors, no? And these are the numbers of patients that has shown that if you give IV iron, you will definitely have a reduction in ESA dose. And it can be even as high as nearly 50% for some of the studies. So the other thing that you need also to remember is the population that you're dealing with. No? So you can see this is in Japan. And we know that Japan is one of those countries that was really able to have very long-term dialysis. And you see here that their mean serum ferritin that they are accepting is around 300, no? As compared to the United States, for example, who would accept up to 800. So you can see why their iron dose is very low in Japan, no? But nevertheless, it is still having a good outcome in terms of their patient. So what is really the information that we need to arrive at when we are dealing with our patient? Of course, we know that IV iron is really needed, no, for full use of your ESA. And we know now, I show you the study that you can really reduce ESA dose. However, these are the safety concerns that has been put forth. No? So you see here oxidative stress, you see here immune dysfunction, increased infection, and these are also the ones that we will like to not see, no, in our patients. And you can see here also the association, however, is not as bad, no, in terms of all-cause mortality and CV mortality. What is really striking is the association between IV iron and the risk of infection. No? And in fact, that is one of the questions, and that is one of the issues why we have been slow in trying to adjust our iron and ferritin dosages. So of course, the problem with iron overload, which also is very difficult to manage. And because of that, KDIGO came out with controversies conference. No? In fact, I think it's one after the other. No? That they came out with this after 2013 and then in 2016. And actually, they were convening in 2019. And in fact, in 2019, they were not only talking about iron now, but they were talking now about your other important additive, which are your hip stabilizers. So it's just unfortunate that the pandemic happened and now they're not able to release their guidance. No? But just to share with you, as far as the 2016, they were able to come up with these guidelines. Use ESA to correct anemia when hemoglobin is less than 10. So not to start off if your hemoglobin is more than that. No? And the target is very narrow, 10 to 12, but you can see here individualized for some. And the lowest possible ESA dose is the ideal way to go. No? And if you are going to use iron, and IV iron can be used. For example, these are hemodialysis patients with an access, then that is the ideal way. In fact, even in non-dialysis CKD, oral or IV was written here, no? And in PD patients, well, that's another area wherein IV iron use will be difficult, no? And the ferritin was set forth here as not to exceed 800. So now they're allowing this high ferritin to be able to drive the use of IV iron. And in fact, after that, and just in their ERA EDTA, they were able to share again the proactive trial. No? So I'd like to just go through fast with this trial. This is a the pivotal trial. So this is a proactive high-dose IV iron that was used as compared to reactive low-dose iron. And they would like to see that the hard outcomes, which are mortality, CV events, will be affected or will be different in the two arms. No? So this was in the United Kingdom, and you can see 50 sites, 2,080 patients, started in 2013, and it's now available. You can read it. So the event rate that they were assuming is a 3-year event of 40% in the placebo group, and the sample size, as I said, and 631 outcome events were required to be able to exclude a non-inferiority. And superiority testing would occur if non-inferiority is confirmed. So this is how they designed the study. These are incident HD patients, only 0 to 12 months, on ESA, and the ferritins are less than 300, TSAT less than 30. They withheld if ferritin became more than 700. And the proactive arm gave IV iron at 400 milligrams per month. And the reactive arm was giving IV iron at 200 microgram per liter to target a TSAT of less than 20. So these are the primary endpoints. It's a hard endpoint, which is fatal CV events. It's a MACE. And these are all the secondary endpoints that they identified, no? And these are very good secondary endpoints as well. So you can see here, as of the end of the study, 2,141 and 1,093 in the proactive versus 1,048 in the reactive arm. And you can see here the mean cumulative dose of your iron reaching up to 11,000 as compared to this value of 6,000 in the reactive arm. And this is the ferritin level as well as the TSAT level, which is very much different between the two. So you can see here the ferritin reached to about 600 and the TSAT was also higher. No? And these are the results. No? So you can see that as far as non-inferiority, the p-value for the MACE was P of 0.001 and 0.04 for superiority. So it was really a very good study, no, in terms of differentiating proactive and reactive iron. And these are also showing to us the primary endpoint of recurrent events. So actually, as far as the result, the p-value was different for the primary endpoint, but for all the secondary endpoints, you can see here, and these are also important endpoints. For example, stroke, also vascular access thrombosis. There are no difference between the proactive and the reactive iron arms, so in these two populations. So the difference actually is the median cumulative dose. And I think this will give us confidence that we can really use high iron dosages. So they were using at the end of 1 year 3.8 versus 1.8 gram. No? And the monthly median doses was around 264 milligram for the proactive versus only what we usually do, which is 145 for the reactive arm. So that gives us a leeway now on how much we can use. So you can use as high as 250 monthly. And as far as the type of dialysis, for example, whether it's catheter access or comorbidities, you can see that the primary endpoint did not matter, no? Except only for this endpoint, which is dialysis catheter, which was the one showing the proactive arm even to be better. So for the 3 cardiovascular events, which are fatal, non-fatal stroke, MI, and hospitalization, you can see that the p-values here are as written, not to be different in the pivotal trial. So this is how the hemoglobin was reached, no? At the end of the 3rd month, it was already arrived at in the proactive, and this is how it was lingering with the reactive, no? Slowly increasing, but you can see that it leveled off, diminish a bit, and then remain stable. And at the end, you can see that both of them would have the same target hemoglobin. So as far as safety, which of course is what we are always looking at when we would have a new trial, and infection, as I said, vascular access thrombosis, and hospitalization are endpoints that we would like to know. So you can see that these are the same in the high iron dose and the reactive dose. And even infection episodes were looking at the lines here, they're really one on top of the other. So no difference between the high and the low. So in the ERA EDTA, they were saying that if only there is no pandemic, probably they would have met and they would have changed the guideline already to say that there is a need to now change their recommendation as far as iron being IV, which is better, and targeting ferritin even up to 600 and allowing up to 250 milligrams per month of iron use. Okay, so let me go now to the next very exciting treatment that will be available soon. And these are your hip stabilizers. And I will like to call this particular treatment modality as a important drug that will allow coordinated erythropoiesis. In other words, it will act like a somebody that is doing the orchestra, no? Somebody who is conducting the orchestra, and it will now put everybody in its correct position to be able to have the final better hemoglobin level for the patient. So these are the milestones wherein the hip pathway was clearly defined. No? It was during the time wherein the EPA gene was cloned, they saw a regulatory DNA element in the EPO gene, and they said that this EPO or this DNA element conveys oxygen-dependent regulation. So they found out that these are your hypoxia-inducible factor or HIF, and they further defined the composition of this HIF as HIF 1 alpha and 2 alpha and HIF beta. So the HIF alpha are the ones that are oxygen regulators, and the HIF beta are constitutive or binding partner. No? And the two is important to be able to proceed with erythropoiesis. So actually, proof of concept of this idea was that they found out that there are some people who have CKD living in high altitudes, and they have enough EPO being produced. Also, they found out that specific diseases like viral hepatitis, ADPKD are also likewise different, no? And this is just another area wherein the proof is really shown by people living in high altitudes in the United States. They have CKD. So this is how the ESA dose is lower requirement in this patient, and their hemoglobins are higher. So there must be something going on with this patient that is allowing more erythropoietin endogenously being produced by themselves, no, to be able to allow erythropoiesis and hemoglobin to be better. Of course, this does not come without a price. No? We know that the HIF have a lot of target genes. You can see here, for example, angiogenesis, vascular tone, even glucose metabolism, even apoptosis. But it seems that the expression for erythropoietin or erythropoiesis and iron metabolism really stand out, no? As far as the HIF target genes are concerned. No? And another proof of this is that in normoxic states, you can see that there is really no staining, no, of the HIF expression. But once they were subjected to hypoxia, both the HIF-1 alpha and HIF-2 alpha, more so of the HIF-2 alpha, were increased during the hypoxic state. So that is how they were able to say that the HIF-2 alpha is the one that is involved in erythropoiesis. So just to show you again the cartoon that I presented a while ago and how renal EPO production and HIF stabilization matters. So you can see here the myofibroblasts and the oxygen consumption in the tubular cells, as well as the oxygen supply. And once there is hypoxia, you can see that these cells now, the ones that I told you is responsible for EPO production, they are now differentiating and they are now better in terms of producing erythropoietin. So the proof that I told you a while ago that there is really transformation of these EPO producing cells, which is shifted by the balance and now the crosstalk between cells in terms of what they need for erythropoiesis. No? So this particular mechanism, therefore, which initially was thought to be irreversible, can be overcome by hypoxia. No? And it's one way to understand how regulated erythropoiesis can proceed, no, with this HIF stabilization. So how do we target this HIF for the treatment of anemia of chronic kidney disease? No? Just to show to you again, under normoxic conditions, your HIF coordinate the physiologic response to systemic hypoxia by altering certain cell types, which will lead to increase in EPO production. So if there is normoxia, you can see that HIF will be degraded, no, by your proline hydroxylases enzyme, and you will not have any hip alpha. No? However, under hypoxic condition, you can see now that this particular process of proline hydroxylation will not happen because of the need to associate with your hip beta. This is dimerization. And these two, hip alpha and hip beta, will now enter the nucleus, which will allow transcription factors for erythropoietin. And so erythropoiesis can proceed. No? So it is in hypoxic conditions that this will happen. And that is why it is called hip stabilizers, because it stabilizes your hip alpha so that it cannot be degraded. No? So your hip stabilizers, for example, your later I'll show you roxadustat, the prudustat, vadadustat will be the one that will act in this particular pathway. So there is no degradation, and your pathway will proceed towards hip alpha and hip beta towards transcription for erythropoiesis. So it is a coordinated erythropoiesis because you can see later on that it will also decrease your hepcidin, and it will even allow as well the use of iron from your stores. That is the important thing about this pathway. So just to show you again how the hypoxia response pathway is different in normoxic condition when you have hypoxia. So the other term is also your prolyl hydroxylase enzyme degraders. So you can see that this is how it will proceed. But if you have hypoxia, this will not be acted upon, and you will have your hip alpha and hip beta be allowed to enter the nucleus, and therefore you will have hypoxic inhibitor factor stabilization. So the nice thing about this coordinated response is you can see, as I told you, there is improvement in hepcidin, actually, no? And once you have this, you now can very well understand why once you have hepcidin as a factor that is addressed, you can now allow iron to be absorbed more in the duodenum. Also, you can allow now iron to be released from the macrophages, from the spleen and the liver, and that will now also lead to your coordinated erythropoiesis. So this is just another proof that in anephric patients, so these are healthy controls, you can see that following hip stabilization, nothing is happening in the anephric patients. However, in patients who have chronic kidney disease on dialysis, provided they still have their intact kidneys, you can see how there is now erythropoietin production because of the endogenous coming from liver and kidney that is stimulated by your hip stabilization. So that's how this coordinated response has been also discovered and proved. No? So to summarize, hip upregulates your divalent metal ion transporter, so making your absorption easier. Even transferrin transport here can proceed, and iron is also released from the transferrin site, no? And also your hip will upregulate your coreceptor, your EPO receptor, and endogenous EPO production in the kidneys, no? And also your hip can upregulate your transferrin receptor. Therefore, iron uptake will be also smooth, no? And the last two will be the formation of fully functional mature erythrocytes, no? Because there is EPO, there is iron. And finally, of course, even your erythropoiesis, those in the marrow, they said can be stimulated, And in fact, the lifespan now after this will approximate 120 days, no, for these erythroid cells, no, because also of the availability now of iron from the storage site. So as far as the companies that have been producing these hip stabilizers, no, the first one that came out is actually roxadustat by Fibrogen. Actually, the first one is FG2216, but there was one patient who developed a fulminant hepatitis, so there, it was reformulated. Now it's called FG4592. From AstraZeneca, there is also your, from Akebia, there is Vadadustat, GSK, the Prudostat, and from Bayer, Molidustat. No? I think the Philippines has been actively participating in all these trials for Roxadustat, the Prudostat, and Vadadustat. No? And I think a lot of this data will come out now with the hard outcomes. No? So these are the benefit of using your hip stabilizers. You can see number one will be your iron, even a bonus effect on lipid lowering because of the particular action on the acetyl coenzyme. Also, the progression of CKD, because we know that proper perfusion is important for kidneys not to worsen, ischemia protection. But of course, we need to also think about the harmful effect. If you recall, I presented to you a while ago the genes that are targeted by your hip pathway. So just to show you that the early studies with roxadustat are dose-ranging studies, but nevertheless, it really shows to us, no, as far as the hemoglobin response, and of course, other important thing is the mean ESA dose, which was, the hepcidin that was lowered, and it was lowered more with a higher dose here, no, in the roxadustat study. So these are phase 2 trials. But 2 trials with roxadustat has been published in the New England. One are the non-dialysis patients, and another one, the dialysis population. And I'll just show to you the 2 trials. These were both conducted in China. And what they did was in a 2:1 ratio, patients who has been on dialysis were given first ESA and then roxadustat for 6 weeks, 3 times a week for the roxadustat, for a total of 26 weeks. And for this study, parenteral iron was withheld except if needed as a rescue therapy. And of course, the primary endpoint was the change in hemoglobin from baseline and other endpoints as well. No? While for this study, so as far as the dialysis population, this is a big study looking at 305 patients. And the non-dialysis population was slightly smaller. No? So almost similar design for the 2 trials, and both were done in China. So just to show you how the mean hemoglobin rose with roxadustat, no? You can see even really careful with the titration because some would really have very high hemoglobins. And here, you can see the change in hepcidin, no? Between ESA. This is very small change in hepcidin as compared to the bigger change that happened in this dialysis population. So C-reactive protein was also appreciatively diminished. No? So you can see this is the roxadustat arm as compared to your alpha arm, wherein C-reactive protein was also increasing. So as far as the side effects, the baseline characteristic, you can see that there is no difference, no, between the 2 arms. A lot of these patients, ferritin will be harboring at levels of around 200, no? and the blood pressures were similar. So the hemoglobin at the start were likewise similar at around 8.8. No? So to appreciate as well the change in ferritin, so with roxadustat from 191, the change was minus 91. Here in the ESA arm, it was only minus 21. Although as far as transferrin, there was really not much difference in the change, no, between the two arms. So the non-dialysis population, which is 154, again, you can see and appreciate the rise in hemoglobin, although there was some problems with hyperkalemia and metabolic acidosis in this population. And I think even in Vasadustat, they were able to show this as well. So the mean change in hemoglobin in the non-dialysis population was also manifested here. You can see it's also different, although in the dialysis population, it was even more different. No? So these are the other phase 3 globally registered studies of roxadustat. So they are now looking at Japan, the United States, and they will, of course, look at the hard outcomes that we always look for in anemia. The next would be vadadustat. No? So vadadustat is from Akebia. So you can see this population is a non-dialysis, just like the other population that was studied in roxadustat. So 18 years and above, and hemoglobins are even lower here. And also they were able to look at different levels of dosages that were needed. No? So these are the baseline characteristic of this non-dialysis population. A lot of them would be on CKD stage 4. So here, and majority also would have diabetes, and the TSATs as well as ferritin are in the levels of around 284. The blood pressures were also similar, and these were done in other ethnicities. No? Roxadustat is in China. This now enrolled mostly white and Caucasian population. So the important endpoint, which is a hemoglobin response, was very, very different between the two arms. No? This is the p-value. So successful hemoglobin response, in fact, they are even reaching hemoglobins of more than 13, no, for this population. So when they look at the change in hemoglobin, so you can appreciate again here at week 3, starting to rise, but not as much change, for example, in not as much change with hepcidin, and VEGF here was looked at as well. So this is a good outcome, no change in VEGF, not as much hepcidin change compared to roxadustat. No? And just to show you that nausea and vomiting was also common, and hyperkalemia was likewise seen here. No? So there was 7 compared to none who developed hyperkalemia, but there was no metabolic acidosis. No? So these are the ferritin and TIBCs. You can see again, the total iron binding capacity is slightly higher. Ferritins also slightly lower, but they are almost the same in terms of the confidence interval. No? So the last would be the prudostat. Of course, there is also molybdostat, but just to show you that also we are part of this trial by the GSK, and they're doing the ASCEND-ND and the ASCEND-D trial. They also have a trial on 24-hour ambulatory monitoring, and all the hard outcomes will be looked at as far as these hip stabilizers are concerned. So when you look at now the safety of ESA as compared to your hip stabilizers, it seems that if it is a coordinated response, the capacity to overshoot the EPO dose, the hemoglobin cycling also that happens, and trying to also get a good dose would be a lesser problem when you're giving your hip stabilizers. So I think the safety concerns also for hypertension, vascular access thrombosis will not be that apparent in these new sets of drugs. So the other important hip stabilizer that is also being looked at, and there are even two more, no, from Acros and Daiichi. I think this will really revolutionize the treatment of anemia. So we discussed this, the hip stabilizers. There are other areas that are being covered. No, you have here the activin molecules, and now even targeting the EPO receptor. No, as far as activin molecules, this was really discovered, no, by accident. They saw that when they gave sotatercept, which is one of the activin traps, which is a TGF beta, member of the TGF beta family, and it stimulates bone, and they saw also that stimulates erythropoiesis. So a lot of trials now are happening with this sotatercept. So as far as the EPO receptor, it also will be forthcoming, and we are of course excited with this. So these are EPO receptor activators. So you can see that preclinical trials are now underway for this group of drugs. So we also have now GATA or NF-kappa B inhibitors, and maybe EPO gene therapy, no? Wherein we will really target the problem, which is erythropoietin, with this EPO gene therapy. So I hope I was able to go through what is in store for us in the future for renal anemia therapy. It is exciting. It has progressed from one that is very limited in terms of the pre-ESA era to very novel agents that will induce therapeutic effects and closely mimic the body's own response to hypoxia. Therefore, this raised the hope that complications will not happen anymore when we are using our ESA and escalating the dose of the drug. No? So also the non-dialysis population, which is growing, they have disordered iron metabolism as well, no? Also the dialysis population. And we know that administering IV iron will be very important for erythropoiesis. And recently one trial, the pivotal trial, gives us the confidence that we can do IV iron even in non-dialysis, and we can go as high as 300 to 400 a month, and maybe go as high as 3.8 grams a year. And the hip stabilizers or the hypoxia-inducible factor activators, that's another name, no, appear to be capable of replacing ESA therapy. And maybe we will minimize the need also for iron therapy because of the important coordinated response by just targeting your hip. No? These are small molecules that are in clinical development, but a lot already has been in phase 3 trial. It seems that the class share the same mechanism, no? But of course, there's difference in the dosing. Some would be just 5 milligrams, others go as high as 400, and the frequency. So really, it is exciting because we'll have a drug for different uses and giving a coordinated response, leading to a perfect, near perfect erythropoiesis. No? And that is less problematic because we don't really have to do a lot of adjustments. So I think KDIGO will be able to come out with their executive guideline again, and even KDOKI. Start iron first. IV is better. Maybe a little higher, not lower. Achieve and optimize ESA use, achieve partial correction. Do not rely on adjuvant therapy, no additive, no? And we are awaiting the outcome of trials for the hip stabilizers. So I'd like to end with this quote, because we know that we have a new drug, and of course we have an old friend, and that's the ESA, no? And even if we have a new friend, we always cannot forget our old friend. So that's always the case. And I hope I was able to enlighten you a bit about what the future holds for us for anemia management. Thank you.
Thank you, Dr. Gomez. So we'll be going to the Q&A portion. So the first question from Don Hilario, is there a target hemoglobin? Is it the same for male and females?
Oh, yes. So I didn't mention that anymore, but as far as after the important trials, the landmark trials, they were targeting 12 for men and 10 for women. But now it seems that you should not really go beyond um, 12, 12 per both. No? So do not start erythropoietin for anybody who has a hemoglobin that is less than 10. Of course, it's a case-to-case basis for some. For example, if you have a severe heart failure, you really need to increase this level to be able to help the heart.
Okay, next question, ma'am. What is the ideal dose for ESA? Maybe starting the patient on ESA, what is the ideal dose?
Okay, so actually it depends on what ESA you're using. No? So for the alpha, we usually start with 50 IU per kilo. And for the beta, it's also almost always the same. But for the longer acting, for example, darbepoetin, as far as all those researches that I came out with, it's 0.45 microgram per kilo for your darbepoetin. And for pegylated, then it actually depends on if you're converting, no, from your ESA alpha to your pegylated. So the pegylated is usually started off at 30, then you sometimes increase it to 50. But I think we don't have the pegylated ESA anymore, or for some they can still get it, but for most of my patients, I have shifted them to darbepoetin if I like to use the longer acting ESA.
Okay,
So it's not a number, no, that you always need to calculate. For a lot of us, we just start with 5,000 IU or 4,000 for alpha, and then we just increase it gradually. And the monitoring says that for non-dialysis, you can do an every 3 months. For dialysis, if you're still not on target, you can do an every month monitoring. And that is also true for iron indices.
Okay, ma'am. So next question from Dr. Estrella. How helpful are indices like MCV, MCH, MCHC in evaluating renal anemia?
Well, we always ask that of our residents and fellows. But actually, as far as what we now know, it seems that we cannot really depend on this unless we already know that it's renal anemia. These are used mostly for other types of anemia, for example. But for renal anemia, of course, we know that it's a microcytic type of anemia. I mean, a normocytic, normochromic type of anemia. So we don't usually use these indices. I personally have not found usefulness for this, and understanding more and more about the pathophysiology, I don't think it can also differ in terms of how we manage our patients.
Okay, ma'am. So next question. The question is, when do we shift IV iron to oral iron or vice versa? So what is the dose of the iron, IV and oral iron?
Okay, so actually, as far as non-dialysis CKD, the guidance is still start with oral iron. And it really depends on what oral iron you are familiar with. No? For example, if you're using ferrous sulfate and it has only 62 milligrams of elemental iron, then you have to give 3 tablets a day. But if you are on those other drugs that are mixed with folic acid, then you can just give it once a day. But for NDD, if you can, and I have tried this personally in my patients, no? Those who cannot tolerate it, and in fact, it's even cost effective, I tried already giving them IV iron. And I really have diminished the side effect, which is as far as gastric intolerance is concerned, and also compliance is better when you are already giving it, even if it is just once a month. No? So you just have to explain to them that they need to go to your dialysis center and they need to have a negative skin test first. And it gets better and better after they're used to receiving the IV iron. So I think the pivotal trial, if we are able to give this, for example, at a higher dose at 400, and the follow-up will be lesser, I think it will also improve compliance with IV iron. So for the dialysis population, it is really more in terms of response to erythropoiesis, it's more ideal to be on IV iron. And in fact, I think that is one of the reasons why they are not on target. They are not giving IV iron. And they are afraid of the side effect. The pivotal trial says that it's an RCT, no? It's 2,000 patients. And the outcome is very compelling. No? Infection is not increased. So I think this factor of fear is because we don't know. But now we have the evidence. I think we should move on and do the best for our patients. At least should try it, I think.
Okay, ma'am. So there's a question regarding the dosing of HIF. Is it combined with EPO or substituted with EPO as a
So
substitute?
it is substituted. In fact, in the studies, it was compared the two arms, no? So it is substituted. So because you can see as far as how it will have its effect, no? In terms of it stimulating endogenous erythropoietin production. So there are still cells that can be rescued in the kidney, in the marrow, in the liver that will produce erythropoietin. And this is what we will harness with the hip stabilizers. So hopefully we will not be seeing the side effects. Hopefully the dosages will be lower. And I think it is low in terms of how the dose ranging with roxadustat, the prudostat has been seen. No? They're not going above, for example, with the prudostat, 10 milligrams every other day. So that's twice a week orally. So these are the advantages of these new sets of drugs, no? As compared to your erythropoietins.
Okay, ma'am. Next question. If the hemoglobin target are exceeded, would you recommend decreasing the ESA dose frequency of administration?
So I showed to you the study wherein it was the frequency that was diminished. And now our experience have shown to us that in non-dialysis, we can even give it and have a response, even giving it every month, once a month, no, for the longer acting. And that is a proof that we have also improved the hypoxic state of the patient and maybe the iron utilization as well. Or you have decreased the inflammation of the patient. That is why your ESA is no longer required in a larger dose. So when you are thinking about hyperresponsiveness and you have to escalate the dose, you have to first rule out the patient factors, dialysis factors, and comorbidities in that area of importance. No? And if you're not doing it according to the list, it's just like a checklist, no? Then what you will be doing is increasing the dose until you get all the bad effects of a high dose, which is if you're on 20,000 units a week, and I know a lot of, some cancer patients are on those dose, you know, that these are the dosages that will really be a reason for courting side effects with high ESA dose. So the results of the trials were not actually because of the high hemoglobin. It was because of the high ESA dose. And when they're doing the cycling, they give a high dose, then their hemoglobin goes up, they decrease the dose, the hemoglobin goes down again, and then it goes up again when they diminish the dose. That is hemoglobin cycling. No? You're just like tracing a star that cannot be reached, no? Without doing a checklist on what really to do. So if you have already diminished all the patient factors, the comorbidity, then look at dialysis factors. You can also improve that by diminishing inflammatory cytokines, even middle molecules that causes failure of iron utilization and also death of the erythrocytes, early death of the erythrocytes.
Okay, so for the last question, Dr. Dangilan raised her hand. Hi, ma'am. Are you going to ask a question?
Hi, Penj. Baka nagha-hi. Hi, Penj.
Is there a question, ma'am? So we'll have the last question. Do you still see EPO relevant in the future management of anemia once we see the HIP stabilizers being available?
So that is really why I was trying to joke the EPO companies that they really have to harp on their product, because if the hip stabilizers comes along, maybe it will replace the ESA. No? Number one, it's oral. And two, it's not given very frequently. And three, the mechanism is really different in terms of targeting not only the endogenous EPO, but also against hepcidin, against inflammation, and even allowing iron to be used. So this coordinated response, ESA does not have. No, we just is substituting erythropoietin, which is not produced. And although 33 years has given us a lot of good friend with the ESA, that's why I said we should not forget it. I think this is just one of those wherein medicine is proving us that we should always not be contented with what we have, no? And try to look for new areas for treatment, a new area or new drugs to use for treatment.
Okay, so I'm very sorry we are out of time. There are still a lot of questions, but we'll try to ask Dr. Gomez offline for the questions so that she can try to answer it. As for our announcements,
Video off.
I'm going to show you.
Tapos na.
May CS ako. Ang dami. Video.
So for our next week, we will be having another webinar on emerging biomarkers in kidney disease, in acute kidney injury, to be led by Dr. Albert Chua. And a reminder, our business meeting will be on July 12, 2020. Election will be from 8:30 to 5 p.m., while the business meeting will be on 9 a.m. to 11 a.m. Please log on the PSN website to register and update your passwords. Thank you very much, Dr. Gomez and Dr. Chua. This is Anne reminding you of our webinar next week. Thank you for joining us tonight.
Thank you, everyone.